Hello, everybody. I want to thank you for returning for day 2, and welcome to the new people that are here today for day 2. Yesterday was such a wonderful day. I am just so happy and so blessed that you all are here and all of the wonderful information that we learned yesterday. I am so thankful for all of our speakers and all of the presentations that we had. I am just in shock and in awe about the information that we've learned, and I'm just, again, just so thankful. One thing I want to just put back out there, and I want you guys to remember, is that something that Mr. Todd Snowville said to us yesterday is please just don't let the fatigue of the conference get you, and just keep remembering all of the information that you guys learned today and tomorrow and yesterday. I mean, it's so important to make sure that you take this back to your organizations and just in your life. And I know you're going to go back to your office and go back to your life and have so much to catch up on after the past couple days, but don't let that get up with you, and don't forget everything that you've learned here. And even if just 1% of your life does change, and if there's just one thing that you can do and change and make an impact in this way and for the LGBTQ community, that's just 1%, and that's important. So I just wanted to bring that back up because that was just, that impacted me. So I just wanted to say that, and then a few housekeeping items as well. Don't forget, if you are doing Act 48 credits, please make sure you go to the table because there is a sign-in sheet that you have to do for Act 48 that is special for that. CEU, you have to make sure you sign out today as well. And there's a paper to redeem those credits. You have to do an evaluation for ORP, and it's also linked to the YAP app now as well officially. So you can do that there. As well as the app, please make sure you keep that for a couple days. We're continuing to upload PowerPoints to that. And then you can transfer those PowerPoints and send them to your email, so you can keep those and print those yourself if you want to have those. And then make sure you're hitting those buttons when you exit your room. If you're happy, if you're not happy with your presentation, just make sure you hit that. That's good feedback for us to know as well. So that's it for my housekeeping items for the day. Again, we have gender-neutral restrooms out here. If you have any questions, hit up the volunteers with the green stickers on their name tags, and that's about it for me. So I'm going to go ahead and introduce to you Mr. Tyler Titus, from a representative of our advisory committee. Thank you.
So I just want to apologize first and foremost for my outfit. It may not seem like a big deal, but it's kind of a big deal. So I packed one outfit, and that was my outfit for yesterday's panel. And then Sarah stopped and was like, hey, so I have this question. Will you talk tomorrow morning? I'm like, yes. I should have been prepared because she did send me an email several times, and I suck at responding to emails, so it's my own fault. So here I am in all my wonder of a dirty T-shirt and flip-flops. But we're going to roll with it. I want to take you on a little bit of a journey with me. It may be intense. It may be a complete flop. But guess what? You're stuck in the room because here you are and you're waiting for the next speaker. So I have your attention for a few minutes. When I was little, I was just like all the other boys. I had the dirty knees. I was ramping and racing my bikes. I actually think that I was much better than they were, but I'm sure that they thought the same as well. You could always find me out in the woods. I loved being in the woods. It was my most favorite place to be. Do you guys remember the Blair Witch Project when that came out? So I made my own version of the Blair Witch Project, and it was a lot of fun. And then I made my friends watch it, and then they had to pay me to watch it. So I was a young entrepreneur in all that sense. But we did a lot of pickup games too. So whenever the neighbor boys were out, I would be the captain of the team, and we had the football games going, kickball. But football was absolutely my favorite because we could tackle people. And then we moved into the teen years, and I was the epitome of an awkward teen. Everything about me was awkward, from the way I did my hair to the clothes that I picked out. I've gotten a little bit better, but not a ton better in that regard. And I would, whenever a girl would talk to me, I would literally just lose my words, usually stare down at the ground. Still happens today, too. It just is what it is. I know these about myself, and I'm okay. And every now and again, there was an occasional boy who could have the same effect on me, but those were pretty rare, and they had to be a pretty special boy to have that impact on me. But some of the things about me weren't clicking into place. I was watching my peers find a footing. I mean, they were awkward too because we're all in this puberty thing together, and puberty just sucks. But they were finding a footing that made sense to them, and they were kind of making sense to themselves, and I could see their confidence boost up. I could see them find outfits that they like to wear, and they would tweak their hair the right way, or, they just had a sense of ease, and that ease wasn't coming from me. In fact, I just felt more and more uncomfortable, and it was getting weirder and weirder to be in my body, and I was starting to really become an introvert. I stopped hanging out with anybody. I don't know if you guys were here yesterday listening to the panel, but Preston gave me the words that I haven't had before, and he said it was humiliating. It was humiliating to be seen by anybody, and that became what it felt like for me to go be around anybody. Is even if they were being kind and gentle and accepting to me, I was humiliated to even be noticed in this body because it just didn't feel right. Because even though I was just like all the other boys, I wasn't like them at all because I was a female. Everyone saw me as a female and received me as a female. And it wasn't until 30 that I came out as a trans male and began my transition. So even though I could feel who I was internally, I didn't have the words. So I went through all of this. I was going to the PCP, I was going to my therapist, I was going to the guidance counselor, and I was baffling all of them. They just kept saying, oh, it's depression, it's anxiety. As you get older, once you go through puberty, you're such a pretty girl, you'll find your way through this. You're just in this awkward phase. And what I heard was, you're broken, we don't understand you, you're flawed, like this is all in your head, like this doesn't make any sense, you don't make sense to us, you're not valid. And that's what I started repeating to myself over and over and over again. And whenever I would kind of dip my toe into trying to explain it a little bit further, I saw like just the fear in the people's eyes when I would try to explain myself. And I didn't want to do that. I especially did not want to do that to my family. So before I left high school, I had 2 suicide attempts. It wasn't because I wanted to die. It was because I didn't want to exist as who I was anymore, and I couldn't imagine a world with me in it. I couldn't imagine a space with who I was in it and how this world would contain me, and I really could not fathom how my mother would have to go and tell everybody, or my siblings would then have to go defend me at school. So I thought it would be much easier for them to just bury me as Tiffany than have to explain to the world that I was Tyler. And that is the truth for so many trans and gender nonconforming youth, is that we just think it'll be easier and that the world would be a better place if we didn't exist in it because the world isn't set up for us to be in it. I wanted to explain to people the words, but I didn't have the words, so I couldn't explain the things I didn't understand. And I felt so much pressure, and I still feel so much pressure, and I feel a lot of pressure even standing up here on the stage because I know that there are 40 to 60% gender nonconforming or transgender youth who are seriously contemplating committing suicide. That number isn't going down. It's not going down. So every time I get on stage, I feel this weight of the world to like make sure that the place is safer for them because they need you, Tyler. They need you. And this is what it's like every time I walk into a provider's office. Every time I go into the doctor. Every time I go into therapy, I want to make sure in that moment I know that they know I am valid. So I try to share as much as I can in that moment so that they can see me, they hear me, and that they believe me. And it's exhausting. It's exhausting to have to keep proving myself over and over and over because I'm so afraid that that provider is going to write in my chart that I'm actually like I have a personality disorder or that I have something over here and it's not actually my gender. And then that person stands between me and my authenticity. They're my gateway. If I don't impress them, if I don't convince them, they can stop my life from happening. And that's what it's like for trans people and gender nonconforming youth, is we need that provider to believe us, because if you don't, the way the insurance system is set up, we can't continue to be authentic. And it's scary and it's frustrating, and that is why you will see so many people like just get anxious and depressed or not even come at all because what if I say the wrong thing this time and I screw it all up? And I'm scared and I don't want to have to live like that. And I don't want these kids to have to live like that. There's an estimate that 1.4 million people in America identify as trans. So 1.4, or or gender nonconforming. But that's really just an estimate because we're not able to be counted on the consensus, so that we don't actually know. And we have an administration, we have policy right now that's actually trying to work harder to erase or delete us from a lot of things. And so our numbers are being even more skewed. So all we have are guesses and estimates. But what that means, if we have 1.4 estimation, and we know that 40 to 60% of those youth who are identifying as trans and gender nonconforming, we know that the numbers are going up. We know that the numbers are going up, which means more youth now than ever are going to need adults to rally around them. The other thing that we know is that youth are overrepresented in all this, in child welfare and homelessness and the juvenile justice system. So LGBT youth are overrepresented, meaning that they're experiencing more abuse, neglect, and trauma than perhaps their peer counterparts, and that result in isolation and rejection and leading to homelessness. And we know when a youth is homeless or when they're rejected, they're more likely to be trafficked, or they're more likely to be identified in sex work or be pulled into it. So all the statistics are leading to a very pivotal moment in our history, and that is we have to do something about it. Our teens need us. Our adults need us. Because the other thing that we're finding is, yes, they're coming out, and then they're able to live their lives, but then when they need to go back in where they rely on other people, our aging population has to go back into the closet because it's not safe for them, because the nursing homes aren't set up for gender nonconforming queer people. There's another thing I want you to know, too, for me, and I can't speak for every gender nonconforming or queer person, but for me, when I feel this pressure to make sure that my presence is on point and that people can understand and they hear me and that they believe me and I'm valid, I remember what it was like to be a child, and I'm instantly shot back to that space. I was diagnosed with PTSD a couple months ago, but I've known a majority of my life that I had it. So what happens when somebody has PTSD and they're triggered, they're reactivated? A whole lot of things could happen. For me, I often freeze, or I will go into a panic state, and I'll have a panic attack, or I'll dissociate right on stage. And that's not uncommon for me to do, actually, when I present a lot. There's a layer of dissociation. But for some people, they can see anger, you can see irritability, you can see frustration, you can see a lot of things come out. So sometimes when a person is coming in and they're triggered and their PTSD is activated, or whatever state that they're in, you might see this angry person coming in, and then that pushes the provider away from them. They're like, well, we don't want to help them. Like, oh my God, we're here to be on their side. Look at how they're treating us. But it's because they're back in that activated state. So I think it's really important for us to understand that we don't know what led that person to that emotional state or that brain state that they're in when they're coming before us, and how terrifying, absolutely gut-wrenching terrifying it is for a transgender, gender nonconforming, especially a transgender person, a woman of color, to get in front of an office or a provider, to get in there and to start being vulnerable. Because we've experienced so many layers of rejection, oppression, and isolation, we automatically assume that you're going to be one of them. We just default to that response. And so we're always on edge through the whole process, thinking, are they going to accept me? Or are they going to reject me? And we're waiting, and we're looking for the signs. So yeah, sometimes we come across as a little bit more irritable. Sometimes we come across as a little short. Sometimes we don't share all of our information, because why am I going to divulge all my information if I'm just going to have to tomorrow go find a different doctor? So sometimes there's a layer of trust that has to be earned before we'll completely divulge our whole history. So what I want to leave you with is some asks. So my call to actions. What we need from our providers are, number one, safe spaces, 2, competent providers, and 3, we need allies. I'll go back through these a little bit, just to kind of flesh them out. 1, safe, welcoming spaces. It's the little things. This is the things that we can do that don't cost us any money. I mean, the magazines might cost money, or the posters might cost money. But if I could see myself up on the wall, if I could see an androgynous client up on the wall, if I could see a trans woman of color up on the wall, if I can see a rainbow somewhere, it instantly puts me at a little bit more of ease. And it doesn't cost a lot of money. If I can see a space on the intake forms that say sex and gender, if I can see a spot that says legal name, chosen name, little lines where I'm able to fill things out and I'm not just having to mark off a box, it changes the dynamic instantly. We need competent providers. This is an amazing, amazing platform and an amazing start, and I am so grateful to see that this room is filled. When I was in high school, I would have never imagined that this many people, this many adults, would show up to a space to learn about people like me. And it's mind-blowing and it's humbling, and I'm so very grateful. And it's a start. It's a start. We've got to pull more people in. I see a lot of people saying that they are, that they are competent with about an hour of training. And I assure you, there's much more than an hour to me or any of my experiences or the layers that I've had to travel. And this is an ongoing process. And when you add in any other layer of minority, if you add in Latino, if you add in a person of color, you have so much more depth you have to cover and travel. So we need the competent providers. And we need allies. We need allies more than we've ever needed allies before. We need space at the table, and we need you to get us there. If you are somebody who has a spot of privilege, which we all do because we're sitting at a really nice hotel and we're listening to some great presentations. We all have a layer of privilege here, being here. And we need our allies to use it. So not just speaking for us, but also making sure that we get a spot at the table so that they can hear our voices and hear our experiences. We need people to push back on the social norms. So maybe that's as simple as, interjecting when you hear a joke. Or maybe it's as big as, hey, this policy is really exclusive. What can we do to make it more inclusive of all of our patients? And I would be remiss if I didn't say we need votes electing officials who protect minorities and not delete us. Votes matter. Votes matter. So the last two call to action steps that I will give you are 1, educate yourselves, so that 2, you can educate others. Educate yourselves not just on the LGBT, but knowing the queer people of color's background, the trans body, the gender nonconforming, the intersex, the asexual. Know where the resources are. Don't wait for an LGBT person to come in front of you to scramble to know where the resources are. Have a list ready. And then once you feel that you've got, you don't have to be perfect, and it's okay. But once you feel that you've got some more resources, start sharing them. Start educating those around you. Not just those who get it, but go to those who don't get it. Normalize asking about pronouns and gender identity and giving out resources. So to summarize, we need safe spaces, we need competent providers, we need allies. And my call to action for you would be to educate yourselves so that you can go on and educate others. Because I need you. I need you. The kids need you, and I can tell you I am tired. I am so very tired. And I know many, many queer people are tired too. We will keep fighting because it is what we're going to do, and we will persist. But our voices would be so much louder and the impact so much deeper with all of you beside us. Thank you.
Welcome to the Conversation Cafe. So we're going to do something a little differently this morning. Rather than just having a group of experts, which we will have, I'll introduce them in a moment, we'd really like to get everybody in this room involved in a conversation as well. So if you look on your tables in the middle, there's a phone number. It'll also be up here on the screen shortly. What we'd like to do is have everybody text in their questions, their comments, their reactions. And what we're going to do is we're going to incorporate those as part of the overall conversation. We don't retain your phone numbers. Everything's encrypted, so please feel free to be yourselves, be honest, and express how you would like this to go. So the three experts that are joining me right now, Morgan Faeder, Stuart Fisk, and Amy Shanahan, they represent a collaboration between Allegheny Health Network, UPMC, and Western Psych. They work together to serve the LGBT community, and we're very honored to have them get started here in just a few moments.
To treat me, you have to know who I am. I identify as a Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man. I was diagnosed with anal cancer. And when I'm dealing with something medical, it's extremely important that they know who I am. Every doctor I've been to, and there were 7, all of the nurses, all of the assistants, everyone treated me with respect.
It is as important to know somebody's sexual orientation, and even more than that, what their sexual scenario is, as it is to know if they're getting a good night's sleep, or if they have a good appetite, or if their bowel movements are normal. It's all part of basic bodily functions that are required for a maximum quality of life.
It's important to have an open and honest relationship with your patient. And so if you do not know what their sexual orientation is or how they identify, that patient is not going to feel safe telling you everything that they need to tell you for their proper medical care.
Knowing a patient's gender identity and sexual orientation helps a practitioner to care appropriately for that patient. We see a lot of patients come in who may not be comfortable disclosing that information, and routine testing or screening may be missed for that patient.
When I was about 15 years old, I remember going into the doctor's office, and my doctor was very warm and very welcoming. She was asking me all the questions that she's supposed to ask to an adolescent. And I remember telling her when she asked about my sexual activity if I use condoms or anything like that. And I said, no, I'm gay. And I just remember her face changed very much, and her warm tone of voice turned very harsh. And it seemed as though she was rushing me out as quickly as possible.
As a lesbian, unfortunately, when I've been involved with the healthcare system, it's usually hasn't been very welcoming. It's usually assumed that I'm heterosexual, and so the questions go along that line, asking me about the need for birth control. And then I fill out forms that ask me if I'm married, single, divorced, or widowed. And none of those boxes apply to me.
I think it's very important to know that what people write on forms does not represent necessarily their reality, and it does not take the place of a provider opening the door to ask questions.
And you need to ask those questions in an open and thoughtful and caring way.
Many times, the patient or client want to talk about their sexual health, but fear that they would be discriminated against or stigmatized.
There are a lot of ways that a provider could ask me questions that would make it more likely for me to disclose the fact that I'm gay than not. So I'd rather them ask me if I am in a significant relationship, if I have a partner. And then I'd like them, when they talk about other issues, to not make an assumption that because I'm gay, I don't want to talk about having kids, or that I don't want to talk about relationship issues.
My partner and I and our children were on a family vacation, and my older daughter became sick. She got stomach pains, and we had to go to the local emergency room. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
It's not about sensitivity, it's about respect. It's about humanitarian response to a human being in general.
My partner was hospitalized recently, very severe aortic aneurysm. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
Throughout my pregnancy, I was very much genderqueer, and I did tell them about my pronouns, which ones I preferred, that I preferred gender neutral or masculine pronouns. But the people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it. Certainly, I felt that my healthcare has been impacted. I feel less genuinely listened to, and I feel like there's a huge discrepancy between the care I get versus other people who have gone to the same provider and report a very different experience.
You need to empathize with the patient you're talking to. Give them an understanding that you care to understand who they are. That's all you need to do. You don't have to use the right words. Just be open to being educated on what right words to use and care.
I just transitioned about 4 years ago to start living as a man. When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me, even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status. And upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
I used to work at a health center that did a lot of care for transgender patients, and there was a lot of discrimination towards those patients. There was a discomfort in talking to them. I myself had some discomfort because I didn't have much training in how to work with transgender patients.
The other day, a patient came into the office, and his insurance cards identified him as Adam, although he signed the register as Emily. After being called multiple times by his birth name, he left the office.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
Recognizing the differences of human beings and being able to address the issues and not using one ruler to measure someone else's existence or purpose in life.
My greatest hope for LGBT patients in the healthcare system is that when they go for treatment, whoever they're going to see accepts them for who they are.
And having the people that we choose to be our families be accepted, to have them be a part of the healing process.
And the healthcare system can take care of us just like anybody else so that we can keep ourselves well and get the information that we need.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
To treat me, you have to know who I am, and I identify as lesbian.
Our lives depend on your capacity to care.
powerful stories. That video was published in 2011, and while things have changed, some things still remain the same, which is why we're here. And as an administrator at Western Psych, it reminds me of some things that we did about that time ago, and had a series of trainings to help build awareness and skills for practitioners. And the more we talked and the more we learned, the more we knew we needed administration and leadership involved, and that it was more about not just awareness and skills, it was about culture change. And having a conversation and having a training for administrators and managers is like herding cats to the water and expecting them to take a bath. Nothing against cats, right, Ellen? So we started this notion of cafe conversation like we're doing today, and having an informal conversation. Morgan and I have gone, and other folks in the audience have started off by inviting folks, to managers specifically, to the table with coffee and bread and literally topics to open up the conversation and create a safe environment for people to be uncomfortable and comfortable in that space, to have the language and the space to talk, and for us to listen, to understand what our employees were dealing with and how we could change policies and procedures. So this cafe conversation notion is not just to sit and chat, but also to talk about ideas of how we could do things differently and get feedback from people doing the work and give messages to leadership that can make changes. It also, the thing that I like about the cafe conversation from a personal perspective, I can't help myself in this environment because I'm in a safe place, and I typically don't share a lot about my personal life. But I have over the years at this conference, including the conversation about my mom, who eventually apologized to me a couple years before she passed away. And I think about my own resilience coming out later in my life and joining the community, and how did I survive? Because it would have been easier to just conform and give up sometimes. And it was certainly the love of my wife and my son and this community that helped me continue to go on. And this notion in my philosophy to accept my mom for who she was, too. I couldn't be accepted if I wasn't going to accept her. And I think that that helped my healing process and move forward with that. So I'm just curious, Stuart, in your work, what kind of things do you and your teams do to listen, to understand, and embrace people and notice their resilience and engage them in their care for what you do at the Center for Inclusion Health at AHN?
Sure. So my name is Stuart Fisk. Just a brief introduction. I'm a nurse practitioner. I've worked in HIV care, research, prevention, politics, and street fighting for about 30 years. We can talk about the old days and ACT UP later, but and I currently am the director of the Center for Inclusion Health at Allegheny Health Network, and we work really to try to transform our care settings so that populations of people that have traditionally been excluded from health care have access to high-quality health care that's competent and compassionate, and that we then force our payers to pay us for those transformed care spaces. So it's not a small job, but it's really been really fascinating. I've also worked with the Positive Health Clinic at AHN for the last 20 years, providing health care to people with HIV. So, and I want to start just a little bit kind of like back in my history, because I think the historical perspective is important to hear about, as you know, from my perspective as a healthcare provider. So I was an out queer, white, cisgender male beginning in the early 80s with the beginning of the AIDS epidemic, and ended up in San Francisco working in research, and then decided I wanted to go into direct care for people with HIV. I was working in HIV research. And I went to nursing school because medical school would take too long, too expensive, and I didn't want to be a doctor. So I went to nursing school, and I started my career as a nurse, as a hospice nurse, working in the Tenderloin, which is the inner city part of San Francisco that has lots of single-room occupancy hotels, and at that time they were filled with people who were really cast off from the social and healthcare networks, and very, very high rates of HIV in those populations, and people were dying very often of AIDS without ever receiving any care or acknowledgement that they even had HIV. So I spent about 3.5, 4 years in a place called the Ambassador Hotel, which is a 150-room hotel in downtown San Francisco that housed active substance users, sex workers, runaways, immigrants and refugees who were undocumented, and then a lot of people who just had been cast away for various other reasons. So lots of the people living in the hotel were transgendered. And I came out of nursing school, even though I'd been an out queer man working in groups like ACT UP for a long time, didn't know a lot about transgender people, certainly not as a healthcare provider, because they didn't teach me that in nursing school. So I learned from transgendered people how to take care of them. And I would say, actually, I got schooled, and I got schooled hard, because these were a group of mostly women who had lived through some of the most horrific experiences that I could even imagine a human being go through, and had a sense of dignity and a sense of entitlement that I really found surprising and really refreshing. So that's how I learned. I learned how to take care of transgender people from transgender people who were dying and who were not going to compromise in the last days on the planet. So that was a very complicated situation. It was very tragic and dramatic and really horrifying in a lot of ways, but really uplifting. And I have to say that I learned not only how to be a nurse from those folks, but I learned how to be a human being. So fast forward to today, where the Center for Inclusion Health is specifically really trying to create compassionate and competent health care for all LGBTQ persons, but particularly transgender people, because there are very specific and very definitive needs that they have that are different from my needs as a gay male. So Charlie Borovitz, who's sitting up here in the front row, is our project manager and is doing incredible work in training our healthcare providers to not only understand how to work with people who are transgendered or transgendered men and women who are coming into the health system, but to be competent in their care, so that and we're going to start an initiative where we're going to be training our primary healthcare providers to not just be compassionate, but to be competent, to actually know how to prescribe hormone therapy, how to know how to refer people to surgical reassignment, and how to get that for their patients. So when we started, I really thought that it was going to be a really, really tough struggle. And it's not that it's been easy, but I think partly because we live in a different time and we have people like Charlie who can go out and do this work. We've made tremendous progress just in the training area. I get emails all the time from managers and frontline staff who have just been trained. And, you know, I get these emails and I'm like, okay, here it comes. And without fail, 100% of the time, it's like, oh my God, thank you so much. We've been struggling with this. We have not known how to deal with it. We've at least got some tools now. Thank you. And these are from rural practices sometimes and suburban practices. This isn't necessarily inner city. So we're making progress. There's a lot of work to be done. We have an electronic health record that is completely oblivious, blind, and stupid about sexual orientation and gender identity. And we're actively engaged in rebuilding EPIC to accommodate that, so that pronouns are correct, so that lab values are correctly identified within the appropriate ranges for the individual, so that people are correctly identified when they go into surgery, so that we know what organs a person has. I mean, you know, having an organ inventory built into an electronic health record is not intuitive, but it's really, really helpful, because you not only then know for anybody what organs they have or don't have, but particularly for a transgendered person who's had some surgery, to know what surgeries they've had, and then how does that impact on my plan of care? How does that impact medications I'm going to prescribe or ways I'm going to treat certain conditions? And then there's also the kind of wish list is like, what organs do I want to have, so that we can immediately begin to identify those things and begin to work towards it. The other thing that we've really done a lot of work on is medical policy, which is to change the way that payers pay for this care, so that we're not continually having to jump through hoops to get people the things that they need that are fundamental parts of their right as an individual in our healthcare system. So we've made a lot of headway on that. So we're moving forward, and it's really interesting to kind of like live back in that day when, I saw the surgical procedures that people had in the 70s and 80s as people were dying and still suffering from pain and complications and shame from botched surgical procedures, from illegal hormones, from inappropriate health care. And it was horrifying, and it still happens, right? Right? Yes, it does. It still happens. So anyway, so I think that as healthcare providers, we absolutely have to step up, and we have to address this, and we have to make our systems bend to our will and the will of the people that we need to serve. And we can do that. It's entirely possible, and we're making headway. I think I'll stop there, although, I have to say that kind of in my journey, in looking at the advances to the point where I have a 19-year-old daughter who has friends who are L, G, B, T, Q, and is perfectly comfortable with that. And that, to me, as someone who grew up in the kind of Bible Belt South, is really incredible. But I think we have to really understand we are not there, and we have a long way to go, and we'll get there. Thank you.
Morgan, I don't think I want to frame a question for you. Just your experience is so vast, and you've been so helpful in our work at Western Psych and in the community. And I know our cafe conversations are popular things, just like Stuart said, that Charlie's work at AHN and some of the folks in the audience, Joe and others that I see that go out to Montauk and other community providers and health clinics to have these conversations so that we can start to create a safe space. You can share your experience.
Wait, you put me on that pedestal, and I'll try not to fall off of it. First, I'll introduce myself. I'm Morgan Faeder. I'm in my day job, I'm a neuropsychiatrist with UPMC. But a lot of what I do that I don't necessarily get paid for is medical student education on LGBTQ plus topics, and then education also within the UPMC system, whether it's through Western Psychiatric or other areas of it. And I just forgot what I was going to say. Anyway, so Stuart, for one, I want to thank you for sharing your experience. I'm really, really heartened that we can get people from, the divide, crossing the divide up on this stage today, because it's pretty disheartening to feel like the other major healthcare provider in town is somewhat demonized. So it's really nice to see a face of somebody who's doing really amazing work out in the community for a population that I'm very passionate about. And the other person I wanted to thank was Tyler, who stole a lot of my thunder, I gotta say. One of the things that I really like to talk to people about is not only community trauma for the trans community. As a trans-identified man myself, and as a physician, I still avoid care, quite honestly, because of fear of stigma. And I know how to negotiate the system. I know who to call at the health plan to say, hey, this thing got denied, can you help me with it? Somebody who does not have the access and the privilege that I have. I can really just only imagine how hard it is to put oneself out there to get the care that we need. The trans community, as Tyler pointed out, both as individuals and as a community, has been through a lot of trauma. And I just want to say this again, we can come off as being kind of harsh. We can seem a little bit judgmental or kind of touchy, people will say. When the experience of the person that you're looking at may be to have had every other healthcare provider that they've ever seen deny their existence, refer them to psychiatry. And, you know, I'm a psychiatrist. Please refer people to me, but not because you think there's something wrong because they're trans, because that's not wrong. You know, and basically be denied their existence most, if not all of the time that they seek medical care. Yeah, they're going to be touchy. And I'm going to be a little bit more harsh than other people are going to be. And speaking as in this case, as a medical professional, we all got to step up and deal with it. Okay, so we all, as providers, have been taught the skills or have access to skills to help people become comfortable with us. It's not our patients' jobs to do that for us. We can educate ourselves. And yeah, I'm coming down hard, but really it's on us to make the marginalized people in our community comfortable with us so that we can serve them the way that they deserve to be served. That's why most of us went into a caring profession, right, was to help people. So, you know, we can do that. And we do have the resources to do that. And there are lots of great people out there training people like Amy and to help us with that. So that's one of the things I want to say. I don't really remember what else I wanted to say. So I'm going to hope that we get some conversation going here.
I'm sure it'll come up. There's a lot of really good comments and questions on the screen. And instead of using our provocative questions that we thought about, it sounds like the folks in the audience want to communicate. So the first one's certainly near and dear to my heart, and totally agree with motivational interviewing. I don't know who wrote that, Paul. Did you? All right, who in the audience is going to take that? All right, what's your name? Noah, thank you. Awesome. What I love about motivational interviewing is it truly does meet people where they're at, and that always was a phrase that baffled me because I didn't always see that happening in our care. But it helps me to listen to understand instead of listening to respond, which is tough because sometimes it's all about Amy. And I think that goes to the one point that I saw up there about how do we create an environment of humility? And for me, it's being honest and tripping over my own tongue and figuring it out and coming from my heart. So the bullet there, Morgan, what do you think about that? How do you discuss sexual orientation and gender identity, I assume, is with adolescents and the parents? We get that a lot in trainings and in conversation. More about how do you deal with the parents sometimes.
Sure. Well, just to be clear, I don't generally see patients under 18. So we're going back to medical school for my pediatrics rotation. But in terms of how you deal with anybody where you may be worried about how somebody else is going to react to whatever it is you're talking about, talk to the patient first, get an idea of their level of comfort with whoever else it is, in this case parents, knowing what it is that they're telling you. Assess for safety. It can be, if you out somebody inadvertently or even intentionally, you can be putting that person in a very unsafe situation. So first of all, you need to talk to the individual, in this case the teenager, alone, and assess for the safety of their situation. And that should guide everything that you do from there. If that individual does want help in terms of negotiating the conversation with their parents, then we can totally facilitate that. If they're worried that, their dad's going to kick them out of the house, or their mom's going to cut them off, or whatever it is, somebody's going to hit them, abuse them in some way, then the most important thing is keeping that individual safe. And that's just number one. So, I don't know. You all have more to add to that.
Yeah, I'm an adult nurse practitioner, so I have not worked with adolescent or pediatric populations, although I've worked with very young adults, and have on many occasions been in a room with a young gay man and his parents, who are in the room because that person was just diagnosed with HIV, and sometimes we're actually having to have that conversation about sexual orientation, sometimes about gender identity, and about disclosing their HIV status to their family. So, I think there's a lot of skill in having that conversation, But a lot of it is also about listening. It's about safety. I agree 100%. People, even just coming to a doctor's office as queer or transgender, takes a huge amount of courage. And I think we need to respect that, and we also need to protect that. It goes back to something that a couple of people have said about, we're going to come in the room and we're going to be angry and we're going to have our defenses up and, we're going to be irritable and we're going to, and I'm like, thank God. Like, if you don't go to a new provider with all that armor on, you probably need to go see Morgan. I mean, that's just not, so yes, absolutely. You need to have your armor on because you don't know what you're going to get. And we as providers, that's something that we need to learn and understand so that we can have those conversations to create that kind of environment of humility, safety, and competency that people need. Can I ask one question just about, I'm going to go back to the health system stuff. So, and that's the consent decree, which is ending. How many people here are connected with AHN in some way? Allegheny Health Network, hi Mark. Okay, UPMC? Switzerland. Meaning anybody who is, yeah, excellent. Okay, so I would just say that in many ways, we in this room are going to be responsible to make sure that everybody has access to the appropriate care regardless of the health plan that their employer picks for them or that they get stuck with, right? So we can no longer, or it's going to be very difficult if AHN does not have competent, compassionate care for LGBTQ persons, they can't necessarily just pick up and go across the street. We have to make sure that we have comparable, competent care so that when employers decide to change their health plan, that people can move safely from one place to another and not have shifts in care. That is all of our responsibilities. We are all collaborating in this together. It doesn't matter to me personally what our employer is doing around this. We have to make sure, and I think we will. So I just want to applaud everyone who is going to help make that happen for our patients.
I wanted to add one thing that came to mind about dealing with families, just the whole motivational interviewing piece. Again, with change, there comes loss, and I think in the family system, there's loss as well. So being open and affirming to the family that's dealing with some of the change may help shift the conversation. I'm not sure what the magic answer is, otherwise we wouldn't be having this conversation. But I think some of that is, I wonder if we could just talk openly about loss, but there's so many other questions. What do you think, Morgan? You want to take one of those?
Yeah, actually, I want to jump down to supports that are available for parents of trans youth. PFLAG is one. There's also a group at PERSAD, and I can't remember when it is that they meet, but it's a kid and family potluck that happens, and there are a lot of great parents there who take new parents under their wings and sort of help them go through that process. Those are two good resources. Certainly if you call to PERSAD Center, you can find out when that group is, and PFLAG is that information is available online also. What else we got?
I'll take how important it is it to be politically conscious. It's been a big part of me as a healthcare provider is having a political consciousness and understanding the politics that I work in. Not only the politics of the health system that I work in, but also the politics of the community that I live in and the country that I live in. Politics should not be a dirty word. People should not be accused of being political. You can be political in the right or the wrong way, from my perspective or someone else's, but you shouldn't be accused of being bad because you're political. We live in, I don't need to remind anybody in this room, that we live in highly politically charged times, that we face pushback and rollbacks in gains that we've made already. And I think as healthcare providers, that is... it's going to make the difference as to whether we can provide the care that we know we should provide or can we not. And so political consciousness is important. I think that can be exhibited in a lot of different ways, in small, tiny ways every day, or in large ways through being engaged in the political process, voting, or even going out in the streets. And I spent a lot of time in the streets in the 80s around the AIDS epidemic and trying to get people to just think about what was happening. So be political. It's not a bad thing.
I'll comment on that one also. Actually, just yesterday I got feedback back for a lecture I gave sometime in May to first-year medical students, and it was mostly positive, but one thing that somebody said was, we were all pretty liberal in that room, but why do you have to make it political? I'm like, okay. And, I actually take the feedback pretty seriously. Like, what did I say during that lecture that, may have spurred this response? And unfortunately, I'm sort of coming to the conclusion that when you talk about what is basically human rights for a segment of the population, maybe you just got to be political sometimes. I'm not really sure that my right to access care is something that I should just accept as, a politician has tried to deny me that in some way, or has tried to deny my existence. And I shouldn't speak out about that because it's political. I kind of reject that, I guess. So yeah, I agree. Be political.
So, I don't know. We live in a community that has no real significant surgical options for people, so I don't feel competent to really talk about some of the surgical questions, but I think they're critical, and I think the fact that we don't have anybody within 200 miles of this city that can do this work appropriately is a huge issue. So I'll just say that about those questions. But the comment, just to ask them to sign their insurance name with empathy, brings up an important point. We work in a flawed system that often forces us as quote-unquote conscious providers to act in ways that we don't want to act and to do things that we don't want to do. So I think that humility is important in apologizing for people, to people, that we're asking them to do things that can create discomfort, but that our system is not mature enough to meet their needs as human beings, and we're working on it. And I think that really goes a long way, rather than getting defensive about the fact that, it's not my fault, I'm just told to do this. That is not an appropriate approach. I think we need to be appropriately apologetic, not overly apologetic, and just let people know that we're working on it. And to write letters to the head of the health system.
Yeah, that too. Epic can change, but slowly. So it's good with that. Other things, just as an aside, I would avoid the use of terms like preferred in terms of name or pronouns. It may not be the name or pronouns that an individual was born with. It doesn't necessarily make them preferred. Those are their names and their pronouns. So things like insurance name, legal name, those are appropriate ways to ask for birth name or dead name. But I would avoid, preferred, just because it implies that there's some amount of choice in that person's identity, which really, in reality, there isn't so much.
Yeah, I think that goes along with some of the conversations that we have about terminology, and people are curious about, what's the right way to say something or the most sensitive way to say something without being politically incorrect, talking about different types of politics, but the sex that someone was assigned at birth versus born with are other things that we have talked about in our cafe conversations.
Right, and this changes fairly frequently, so we're all going to get it wrong at some point as new and more appropriate terms are being used by the community. So it's always okay to apologize sincerely and move on. Too much of an apology can make it seem like you're trying to make the person who's affected make you feel better. So try to avoid that. That's not necessarily a good way to go. I'm trying to think of other things. Oh yeah, in terms of the way people refer to body parts, always good to go with what they use for themselves and ask them if it's okay for you to use that. So, you can always say, how do you refer to yourself or this area of your body, or that sort of thing, and then go with that, rather than use technical terms or anatomical terms or even colloquial terms that really may be triggering and very unpleasant for the person.
A lot of curiosity in the room. Surgery for infants, intersex infants was up there. A lot of questions.
Just don't.
Don't? Yeah.
Don't.
That was an easy answer. We don't need to discuss that any further.
Right, just no.
Stop it.
Let's see. Religious exemptions, I guess I'll take that, and maybe you all will have something to add on to this. Most of the major professional organizations have issued statements saying that it's really not okay to deny people care. Generally, if you can't provide somebody care, and this isn't necessarily because of a religious exemption, but you can't professionally, you would always refer them to somebody else. But I believe that at least the AMA and the APA and many others have said, no, this just isn't okay. It's really against our code of ethics.
I would go back to what you said about the the infant surgery. Just say no. I mean, we have to push back against this stuff. I will not kind of make decisions based on that in my practice, and I don't know if I could work somewhere that asked me to. So, but I understand that people do, and that there's ways around it, and sometimes you have to be creative, and a lot of times you have to speak up.
How about handling resistance from providers who don't want to be educated? I'm going to channel the motivational interviewing stuff again. I can't help myself. I wonder if we could rethink about this term. Resistance might be all about fear, ambivalence, not necessarily curious. I don't know. What do you think about any of that?
I don't know, I just yell. No. Of course MI is the way to go. Which isn't to say that everybody is going to come around. You know, there are some people out there who believe what they believe, and no amount of empathy is going to change what they believe. Sometimes we just got to roll with it and, I don't know, work around those people.
Well, and honor their autonomy for their choices, and similar to what Stuart said, you know, refer people out and around them and away from them then. And I've said this in supervision, which I like to create an environment there as well, which is another passion of mine, that supervision has to happen where you can have a safe conversation with your supervisee. But if you don't feel equipped and you don't want to, and you choose not to change your thoughts, or suspend them, I should say, beliefs, then don't treat people in the community. And that's really the conversation that we've had a lot in our trainings, that it's so important to understand our own biases. And I wonder, how do you know that you're triggered, or your buttons are being pushed, or that your staff or employees are expressing their biases, and how do you handle that?
Could I just go back to the last point? So I think that in terms of providers who are resistant, ambivalent, whatever, I think our first responsibility as health systems is to provide providers with the tools that they need to understand the work and to do the work that they need to do. And so if we're not training people, if we're not educating people, if we're not giving them a health record that allows them to do their job in an effective way, then we have to solve those problems at least simultaneously. If not first. The second thing is that it really depends on what that person is resistant to. I mean, we see this in a lot of the populations that we work in, not just LGBTQ populations, that there are providers who seem to have the ability to deny even life-saving procedures to people that they don't believe deserve those procedures, and they continue to be employed. And I have a problem with that. We have policies in our system about all of this stuff, and people need to be held accountable to it. So I think there's a motivational interviewing when somebody's saying, you know, you can't have a surgical procedure that could potentially save your life or keep you from taking your life, is not acceptable. So, and what was the second part that you wanted?
I don't remember.
Anybody remember?
Oh, how do you know?
Oh.
People being, they're biased and their buttons are being pushed and they're with people, and how do you handle that?
Yeah.
Staff.
Yeah, so with staff, I think, one of the things, at the Positive Health Clinic, which is really the place where I do all my clinical work, we have morning huddles, we have multidisciplinary teams, we work together, and when it comes to things like pronouns or appropriate health care for our LGBT patients or any of our patients, we really support people to correct people and to address what people are doing and do it in a way that is respectful. So, we'll sit and huddle and, we'll be correcting pronouns around the table sometimes, including me, right? So I need people to look me in the eye and say, not the right pronoun. And I need to learn that. And I need to be humble about that. So I think that creating a work environment where people can correct each other. I mean, if I'm sitting around a table with a bunch of providers and I say, I'm going to start this person on this medication for this, this condition, and it's not the right thing, I expect my colleagues to say to me, no, don't do that. That's not appropriate. And as a healthcare provider, if I can't take that kind of critique, then I probably need some motivational interviewing or more.
Okay, medical gatekeeping. This is one of my favorite topics. All right. And one of the things I'm actually really very passionate about, I'm going to put out there that I don't think that being trans is a medical condition, whether it's binary trans or non-binary. It is something that, an identity where we need help from the medical system in order to be able to realize what we need in order to realize our full selves. So I have a real hard time with gatekeeping in general, seeing as I don't really think that I need any kind of doctor, psychiatrist, psychologist to tell me that I'm right about who I am, and I don't think anybody else needs that either. The problem with that is that is not how the world works right now. And so anybody who's looking for gender-affirming treatment or gender-affirming procedures is going to have to go through some gamut of either an informed consent discussion for hormones with their primary care provider or endocrinologist, or some kind of gauntlet that they need to run to access surgical services because a psychiatrist or a psychologist said, oh yes, they're trans enough, in air quotes, that they're somehow believed by the medical establishment to have the identity that they have. And then for non-binary people, where I think this is going, is it even gets worse. Because then we're not even sure what this gender thing is. Are they a man? Are they a woman? What do you mean they're not a man or a woman? I don't know if I can sign off on that. And so then there's the issue of, does somebody need to have accessed hormone treatment in order to access surgical services? And the answer should be no, really. That there's nothing about somebody's gender identity that means that they need masculinizing or feminizing hormones in order to be able to have whatever surgical services that they need in order to affirm their gender identity. So I'm not really sure where this was going, except that I want to put out there that gatekeeping is generally not a good idea, and we need to be fighting against it. I don't know where the WPATH Standards of Care 8 are going with this. In general, there has been a trend towards less gatekeeping, but the medical establishment is very protective of not only its power in some sense, but also the idea that if they make a wrong decision I should say we make a wrong decision in terms of granting somebody access to care, that then there could be legal consequences for the person who did that, whether it's the surgeon or the person prescribing hormones or however it turns out. Basically what we need is advocacy to address this. We need people who are at the who are parts of the bodies who are producing standards of care like WPATH, standing up and saying, this is wrong and this is why it's wrong. My identity is not a topic for a medical professional to certify. And then we need to go from there. This also brings in the issue of, do you need a diagnostic code of some sort in order to be able to have insurance pay for gender-affirming services? Then you need advocacy with, regulatory bodies and insurance companies and legally in laws in general. And I think that basically we're sort of at the beginning of working on all of this, and it takes a bunch of people standing up and talking about it and saying that they don't agree with the way things are now in order to move things forward. So I think the answer is we got to get political.
Well, there's a flip question about managing patients who make staff feel uncomfortable. Whew. A little background on that question. I'm going to make an assumption, see if we have some nodding heads about maybe I'm in the community and patients are disrespectful. Is maybe that the context of the question?
It's my question.
Okay.
Manage a lot of folks from a variety of different identities, and this goes across LGBTQ spectrum, but also we've had issues with patients who refuse to be seen by people of a certain race, and it's always a challenging issue for us in terms of how to address. And I'm just looking for some feedback as far as your experience in terms of how to be caring for your patient in that scenario, but also protecting and caring for your staff.
I would add coworkers too, because often our staff are not treated well by coworkers sometimes. So, that happens a lot. I mean, we have a waiting room in our clinic that's shared by an internal medicine program and the Positive Health Clinic, which is an HIV program. It's a very diverse waiting room. It goes from, homeless, people, drug users, people of all different races and ethnicities, languages, to lawyers and doctors who come into the same place for care. And I think one of the things that's really guided the work of the Center for Inclusion Health is that by putting all of those people in the same waiting room, there's some risk, right? But there's also then the possibility for learning and decreasing risk and talking to people about their behaviors and, not driving people either away from care or employment unless it's necessary, but to really take that opportunity to educate people. And what I think we found is that when we have those open conversations with people, if it's patients who are being aggressive towards staff or mistreating staff or coworkers or staff mistreating patients, it's all really the same conversation that we have to continually have. And again, we have to give people the tools to understand what's happening in this waiting room, what's happening, and why do you have to act a certain way when you're here. And I think that creates not only individual behavioral change, but it creates cultural change. It's hard, and it doesn't always work well, and it's hard to be, motivationally interviewing correct when someone, particularly your staff or one of your patients, has gotten slammed for being a certain way.
In clinical work, supervision is really important, supporting employees who have pain related to psychic pain related to what patients or colleagues have said. I think that there's a compassionate way or a kind way to tell a person. I was working with someone who actually was passive aggressive with me in my office, and I was just honest about their behavior was hurtful and my intention of my care of this person, and engage them in a conversation about them making choices to be with a provider that they felt more comfortable with, but that I was feeling a little uncomfortable with the pain. But it's really situational and really complex depending on what your aim is. To me, the patients I serve are my priority, and giving the staff tools and resources to do that is the other piece of that. So there's multiple layers. Morgan?
And I think that also just making sure that everybody is safe is important as well. I mean, there was actually a recent issue of the AMA Journal of Ethics that sort of dealt with some of this stuff. And there are differences in terms of why somebody might be asking for a different provider. I may prefer to see another member of the LGBT community because I would feel that they understood my experience better and that I might get better care on that, on those grounds. That's not necessarily an unreasonable request. At the same time, if I said, I only want to see a white man because I think that white men are better practitioners, that might not be something that somebody would want to honor. And it comes down to where the problems are. My general feeling about it is that if you or your staff or the colleagues are in an unsafe place, then that's the time to do something to make sure that everybody stays safe. If it's discomfort around negotiating with somebody how they feel they're going to have their identity respected, then I think a conversation is the best way to deal with that, and usually that can be worked out fairly easily then.
I think we also do a lot to try to match patients to staff and providers. If it's not working, then they get to pick another provider or another social worker, or we have patients who will only communicate through our secretary, and she has become an excellent history taker over the years and communicates medical and other information to us, and then sometimes we have to communicate back through her, but that's who people have chosen to communicate through. So we really try to be respectful of that. Sometimes I feel like this issue of I want a white male doctor has come up in my career, and my first thought is I know a lot of really bad white male doctors that I can refer you to. But I'm not going to do that.
That wouldn't be politically correct, would it? We have about, I think, 8 minutes left in our conversation, and I think the second bullet might be a little easy. How can providers avoid outing their patients to family members? Totally avoid it. Unless you're collaborating and they gave you permission to do that and you had a conversation with them as to how it was going to happen. That's my thought. I don't know if anybody... Stuart, Morgan, have anything to add?
Yeah, I mean, you have to have staff training, and you have to have staff really understand how easy it can be to out people. Working in an HIV clinic, that serves the LGBT community, but also serves people who have substance use disorders and a lot of other issues, some of whom are undocumented. I mean, how you compartmentalize information about people and parse that out to others is really important to think about all the time. We actually had a family who received services at our clinic. They were Africans with HIV, and there was the mother, the daughter, and the daughter's husband all received services at our clinic, and none of them knew that any of the others were getting services with us or had HIV. It was a really, really awkward situation, and we managed it for a long time until we actually recognized that they really did know and they just weren't talking to each other about it.
Sounds like a lot of families in this room, huh? One more question, probably? What do you think?
Can I acknowledge that, yes, there are many Christian communities, churches, also other faiths. I'm Jewish. There are a lot of affirming Jews as well, who are accepting and open and welcoming. And, as actually a semi-practicing Jew, I will speak for religious communities in general. We got to stand up and make that known. That's on us as religious community members to basically advertise our openness and our welcoming. I don't know. Anyway, put out a banner outside the church, a big giant rainbow flag or whatever it is, so that everybody knows, because there are a lot of people who are doing PR for the opposite side, and we got to fight back against them.
One question about helping people get what they need within the current climate, I'm presuming you're not meaning that it's still spring and not summer, rainy out. Maybe we're talking politics.
Or climate change, which I think is the answer. I mean, currently, yes, we need navigators. We need programs like the Trans Buddy program. We need people in our systems that have expertise in resources that our populations need, and we need to acknowledge that we don't always have the correct resources, but that we may know where they are and make sure that people get to them.
And I think for me, from a general perspective, I remember being a tadpole in the field about 25 years ago, and I had a man who I was working with was identified trans man, and I had no clue what to do. And like Stuart, I learned what to do by listening with intent to understand. Thankfully, I knew some of that back then. But more importantly is surrounding myself with mentors, and I have 2 on the stage with me right now, that I reach out to and to get help when I need it, and to have conversations when I'm struggling with what to do and where to go. And so thank you both for your mentorship, and that was one of my pieces to add. Surround yourself with mentors and people that help you.
So I would just close with just an acknowledgement that LGBTQ, there's a lot of layers that go into our community, and there's a lot of what is now called intersectionality. So that race and a whole lot of other social determinants end up entering into how people are treated. So, one trans woman can be treated very differently than another, based on factors other than being a trans woman. So that's where, and again, I think at the Center for Inclusion Health, at least what my recognition is that if we can take all those intersections of stigma and health and social determinants of health and provide excellent health care to that person in the same setting that everyone else gets health care in. So if I can take care of a transgendered woman who is African American, has HIV, has a significant mental health disorder, is homeless, with multiple chronic conditions, then I can take care of anybody. And so I need to be able to take care of that woman, not only because she deserves care, but because it makes me a better healthcare provider to provide care for any of you who walk in the room who don't have all those intersections of stigma and oppression.
I don't even know what to add to that, because that's it. Mic drop. Yeah.